Further ado, I'm going to introduce our speaker this evening. He's here to talk about acid reflux, and his name is Dr. Michael Herman. He's a gastroenterologist with the Center for Digestive Health with the Valley Medical Group. Take it away, doctor, and thank you for being with us this evening.
Thank you for the welcome and introduction, Susan. So yeah, I'm Dr. Michael Herman. I'm a gastroenterologist. I have two offices at the one at the Center for Digestive Health in Paramus, and my other office is in Mahwah. I do my procedures at Valley Hospital, and I do inpatient consultation there as well. I did my training in Manhattan through the Mount Sinai Health System. So I'm going to be talking today about acid reflux. It's a nice catchy title, Feeling the Burn Again, What You Need to Know About Reflux Disease. So I don't have any disclosures. So kind of our agenda for this evening, we'll talk about the background about, acid reflux, which we'll refer to at times as GERD, G-E-R-D, the pathogenesis, which means kind of like the mechanism as to why it happens, the symptoms, which, I'm sure a lot of people can relate to, especially during this talk. Oh, sorry about that. The therapies that we could provide, the various evaluations that we do. And we'll touch briefly on, not terribly relevant to this specific talk, about various endoscopic interventions that are available when medications don't work, which again is quite rare, but are options. So GERD. So what's the definition? Symptoms and or tissue damage secondary to reflux of acid and or normal gastric contents. So it's pretty simple. We eat food, we chew it, it goes in our mouths, it goes down our food pipe or esophagus, and then goes into the stomach. And when the food content or the acid or digestive enzymes from the stomach reflux upwards into the esophagus, we get symptoms. So just a little bit about the normal anatomy here, as we can see. Hopefully you can see my mouse. So this tubular structure here is the esophagus. This is the diaphragm here, and this is the fundus, which is the upper part of the stomach. And there's a little important flap valve here that at the connection between the esophagus and the stomach that basically opens, in conjunction with the lower esophageal sphincter, opens and closes. So when we swallow food and it goes down our esophagus into our stomach, it opens. And then when we're done eating, it closes, appropriately so, to prevent the content that we've just eaten, the food that we've just eaten, as well as any of the acid or the digestive enzymes that our stomach is secreting from refluxing upwards into the esophagus. So why does reflux or GERD happen? So there are multiple causes. We're not going to talk about one of them in detail, but the various esophageal, and I like to break them down as esophageal, lower esophageal, and gastric causes. And today's talk will probably focus mostly on the lower esophageal sphincter issue, but some of the esophageal issues are reduced saliva. Saliva has bicarbonate in it, so when we don't have enough saliva for whatever reason, there's a reduction, an increased amount of acid that goes in because of the lack of bicarbonate. If your esophagus is not moving correctly, there's a motility issue. If there's lack of gravity, which I think a lot of time, that's why we recommend often that people don't go to bed after eating, because we want to allow time for the food to go down our esophagus into our stomach. If we lay down right after we eat, the food in the stomach has a chance of refluxing upwards. Moving on to lower esophageal sphincter dysfunction, which again will be the crux of today's talk, or this evening's talk. When the LES, that lower esophageal sphincter that we showed in this slide here, when it inappropriately relaxes, it doesn't close after we've ingested our meal, that's a big problem. And that's the real reason, a lot of the times we see this, what we call transient lower esophageal sphincter relaxation, where it should be closed, but it's staying open. In medical terms, relaxation basically means it's staying open, it's not closing. The presence of a hiatal hernia, which I'm sure people who have heard of or have had upper endoscopies, when their doctors tell them about a hiatal hernia, usually patients say immediately, well, I don't feel it. Most people don't feel a hiatal hernia. The most common symptom of a hiatal hernia is reflux, because the stomach is herniating upwards into the esophagus. Like we said, the stomach makes acid, and now there's more acid exposure in the esophagus because of that herniation of the stomach upwards. There also could be a problem with the LES, not only that it's, the LES is the lower esophageal sphincter, not that it's inappropriately relaxing, but also it could be just weak, and that could be from old age. As we get older, everything kind of gets a little bit weaker, including our GI tract, portions of our GI tract. Various medications can make it weaker. A motility issue called scleroderma can make it weaker. And then just briefly, some of the gastric causes of reflux. So if the food makes it to the stomach but doesn't empty appropriately and just sits in the stomach for prolonged periods of time, that can, eventually the food can reflux upwards if it's not moving through the GI tract. If there's excess acid production, there's various rare conditions where there's just hyperchlorhydria or a lot of acid in the stomach. So obviously that can, if there's too much there, it'll reflux upwards and cause symptoms. And bile acid reflux is another topic that we won't really discuss today. So various factors in reflux esophagitis. So obviously, we talked about this on the last slide, how much refluxin is coming up can cause symptoms, how long the reflux is going on for, what types of fluid, is it acid, is it bile, is it non-acid? Clearing mechanisms include, being able to move things along not only the esophagus, but the stomach. And the presence of a hiatal hernia also can be a factor related to what we call reflux esophagitis, where there's, again, that term is acid reflux causing inflammation in the esophagus, and sometimes which causes symptoms. So this is just a little schematic of what a hiatal hernia looks like. To my left, I think to your left as well, is normal, and where my mouse is now, the hiatal hernia. So that's actually portions of stomach that's herniating upwards into the esophagus above the diaphragm. That's the diaphragm right here. And as you can see here, we see this endoscopically. We often see this on CAT scans or various swallowing study, X-ray swallowing studies where there's this hernia present. It's quite common, and oftentimes is a lot, the explanation for reflux. So some symptoms. So the most common or the classic symptom of GERD, or gastroesophageal reflux disease, is heartburn. Substernal burning and or regurgitation of food, postprandial, usually occurring after eating, aggravated by change in position, and you get a prompt relief with antacids. So there are some atypical symptoms as well, which some of you may or may not have had as well. So acid reflux can cause hoarseness, cough, globus. Globus means that you feel like something's kind of lodged in the food pipe. You're able to eat, but you just always feel like something's there. Halitosis is just bad breath from the acid refluxing upwards. Vocal cord granulomas, you get these lesions on the vocal cord or ulcers on the vocal cord from the acid. It even can cause something called laryngeal stenosis. The laryngeal muscle can get narrowed from the acid. It also, uncontrolled acid reflux can even cause a laryngeal or throat cancer. It can affect the teeth. Our teeth are not made to be, cannot undergo, sorry about that, cannot undergo that type of acid exposure. So it can cause loss of dental enamel. Pulmonary, so if pulmonary complications are symptoms, so if the acid actually, you aspirate it, it goes into your lungs, you can get lung conditions, asthma, bronchitis, aspiration pneumonias, various different lung conditions. Another symptom is, the classic chest pain. And, obviously, even as GI doctors, someone who has heart attack risk factors, we always get concerned about the heart. So that's why we always want to make sure a cardiologist is involved too, if they haven't had a recent cardiac evaluation. So what are our treatment goals for GERD? So number one, we want to eliminate symptoms. That's, number one. We want to make people feel better. We want to make sure that their symptoms, whether it be typical or atypical, are well controlled. If there is any evidence of esophagitis on, endoscopy, which we'll talk about shortly, we want to make sure that gets healed up, because we'll talk about some of the complications of esophagitis. Again, and we want to maintain remission. We want to keep people feeling well. And remission here, I know it gets oftentimes associated with cancer terms, but it's a loose term here, where we want to maintain people feeling well without evidence of inflammation in the esophagus, and really without major symptoms. So what are the various therapies that we can offer? So dietary and lifestyle modifications. It's easiest, cheapest way of getting better. We'll talk about those. Antacids and topicals. I'm sure some of you who are on this talk have taken Tums, Carafate, or Gaviscon in the past. And then some of the H2 receptor antagonists and proton pump inhibitors, and we'll talk about in detail what are those. So first, the H2 receptor antagonists. So these are your, your pepsids, the ranitidines, the Zantacs, which were taken off the market. And there are some other more older ones that we don't really use that much anymore. They basically block acid by binding to this specific receptor called the type 2 histamine receptor. They work pretty fast. You could use them as needed, especially if your symptoms are mild, or once to twice a day, standing. And PPIs, which we'll talk about as the major class of drugs, some of the studies have shown that it works. Those work a little bit better than some of these drugs, but these drugs actually work quite well. And this is just some guideline evidence-based that these can be used as maintenance options in patients who don't have who have symptoms but don't have evidence of disease on endoscopy. And this bullet point here just talks about this could be used in conjunction with a PPI drug, which I believe we're talking about on the next slide. Yep. So the PPIs, these are like, I like to, refer to these as like, aspirins are to cardiologists. We prescribe these all the time. Things like omeprazole, or the brand name is Prilosec. As you can see, these are the years where, so Prilosec's been around for now over 30 years. Prevacid, Asifex, Protonix, Nexium, omeprazole with bicarbonate is Zegerid, and Dexilant is one of the newer ones on the market that works very, very well for, pharmacologic reasons we don't need to talk about today, but is oftentimes very difficult to get approval from insurance companies. So I'm not going to spend a lot of time on studies or schematics, but this is just a study that showed basically how PPIs, the class of drugs we just spoke about, work, much better over the pepsids and much better over placebo, like a sugar pill that we give patients in studies that showed that in healing of esophagitis, healing of inflammation of the esophagus. And this is just another schematic that shows that esophagitis remained in remission a lot longer when you take, a PPI drug like omeprazole or Prilosec every day versus, only a couple times a week, versus ranitidine, which is one of the PPIs. That's, Zantac. So a lot of the issues we have, because primary care providers are prescribing these drugs also on a routine basis. We get a lot of the referrals when patients are either on them and are not doing better or not getting better, or what the next step when the primary care provider tries to stop the medicine, the patient gets a recurrence of symptoms and don't feel comfortable keeping them on it. So a lot of my evaluation involves, number one, are they actually taking the medicine? Are they being truthful? Are they taking it correctly? And the correct time usually is about 30 to 60 minutes on an empty stomach before meals, usually preferably in the morning before breakfast. Are they taking the proper dose? Should they be on a higher dose or twice a day dose, or at the right time of the day? Could they be responding to one drug versus another better? Could Prilosec in one patient work better than Nexium and vice versa? Do they have refractory acid reflux? And we'll talk about what that evaluation entails. And that basically means, do they have persistent acid reflux despite these medicines? Do they have refractory GERD, but not an abnormal quantity of acid reflux? Meaning that basically means, are they having symptoms of GERD, the heartburn, the regurgitation, or some of the atypical symptoms that we mentioned, but the amount of acid reflux that they're having, what we do on quantitative testing, which we'll talk about in a moment, we don't pick up that they're actually having acid. So what could be the explanation of their symptoms? And could they have other diagnoses or symptoms that are not related to GERD? So obviously we want to take a great history when we're talking to these types of patients. You'd want to consider empirically putting someone twice a day, like Prilosec or one of the PPIs, just to see if they do respond, because that usually is the highest dose we prescribe. And we want to perform additional testing. Sorry about that misspell there, to quantify GERD and assess for potential etiologies. And we'll talk about what those evaluations are. So most of the time, depending on the patient's age, we could usually start one of these medicines without having to necessarily perform an invasive or endoscopic evaluation. So what are the evaluations that we could really do for GERD? So number one, the gold standard is endoscopy. There's barium esophagram. That's basically one of the X-ray tests that I mentioned. We don't really do that anymore for diagnoses of GERD since the advent of endoscopy, decades ago. There's high resolution manometry, which we'll very, very briefly talk about. Used more for patients with swallowing issues, not so much for reflux, but oftentimes is needed in conjunction with some other tests. There's quantitative reflux testing. So that's kind of what I was mentioning earlier, to establish whether the patient has symptoms that aren't getting better with medicine and whether they're truly having acid reflux or not. And we'll talk about, again, just very briefly what those testing options are. And then you can consider doing a gastric emptying study. And that's when all else fails, nothing, you haven't got an answer, just to make sure the stomach is emptying appropriately and not the cause of the issue with, stomach content staying in the stomach much longer than needs to be. And that's the cause of the reflux. So just some images. So this is what we see during endoscopy. This is the tubular structure, the esophagus, which in this picture looks completely normal. Manometry, which we just talked about, again, just very briefly looks at the various sphincters and can give us various pressure measurements. The resting pressure, can give us issues, telling us whether or not there's issues with the esophageal sphincter, what the resting pressure is. After we ask a patient to swallow, what the pressure is. So it gives us a lot of kind of different information that can be very helpful. These are some, again, which we're not going to talk about, but just some of the illustrations, the manometric findings that we get, that help us interpret what's going on with the patient. Quantitative reflux testing options. So again, this is where we have a patient on medicine, they're not getting better, we do their endoscopy, and really depending on what the endoscopy showed, do I make a decision of which way I'm going to go with this? So there's the 48-hour wireless pH manometry off acid reducer. So this is basically what the brand name is, the Bravo capsule that's made by Medtronic, where basically I choose this test where a patient's not getting better on medicine, I do their endoscopy and everything looks normal. I don't see any evidence of damage in the esophagus, and they're still not getting better on medicine. So I'll do this test, having stopped all of their antacids for at least 2 weeks before, and I'll repeat their endoscopy and I'll deploy this Bravo capsule that sits in the esophagus. And over 2 days, you have a little recorder on your belt for those 2 days. You don't feel it. It's inside embedded in the esophagus. And over those 2 days, when you get symptoms, you push a button and you obviously establish what your major symptoms are: heartburn, chest pressure, regurgitation, whatever those are, belching, could be anything that's typical or atypical. And you push a button and it actually timestamps if there's an acid reflux event during that time the patient's having symptoms. The other test, which is called 24-hour pH impedance, this I usually reserve for a patient where they're having persistent symptoms and I do their endoscopy and they've actually got evidence of esophagitis. They have inflammation, ulcerations, And this helps me really determine why they're not getting better on medicine. And we do this test on medicine. And if they have persistent abnormal acid reflux despite the medicine, because remember, we're doing this test on medicine, that could be an indication that they need to have some sort of endoscopic or surgical intervention to correct their reflux disease. So just, I know we spoke a little bit about this. That's what the Bravo capsule looks like in the esophagus after we deploy it. This is obviously a little bit, not as appealing, which is why I kind of, don't do this as often, but there again, different indications. You go home with a nasal catheter that, the catheter goes into the esophagus and sits in the esophagus and comes out very thin. You don't really feel it. And it's 24 hours. And this little recorder sits on you as well, on your belt as well, for the same kind of thing where when you develop symptoms. So this just is a table schematic that looks at, various diagnostic tests in GERD. And as you could see here, evaluation of trouble swallowing or mucosal injury. Endoscopy is superior. Manometry is really the only, it's only superior in, for someone with swallowing. But again, usually most of the two tests that we're doing here are these two, the two in the middle, the endoscopy and the ambulatory pH monitoring. So we talked a little bit about this. So refractory GERD. So you have typical or atypical symptoms, not responsive to medicine, and testing confirms excess acid exposure despite medication. And usually we see this on, with the 24-hour pH impedance on medicine. So what happens when we have one of these diagnoses? So there are various, traditional surgical and newer endoscopic options for someone who has symptoms despite medication. So the traditional surgeries, which we'll get a slide or two on each, are the fundoplications, and that whether it be the Nissen or the toupee. A Nissen is a full 360-degree wrap. A toupee is a 270-degree wrap. There's a magnetic sphincter augmentation called MSA. And again, these are a little bit complicated. We're going to briefly just touch base on them and show some images. And then some of the endoscopic options are the TIF, the transoral incisionless fundoplication, radio frequency energy delivery, ultrasonic endostapler, or ARMS, ARMA, which we'll talk about. So when do we want to do these surgeries? So, if there's indications, the indications are when we want to, if they have persistent symptoms despite medicines, and there's a reason not to stay on the medicine. There's a cost aspect, although nowadays most of these are covered by insurance. If there's a compliance issue, there's significant side effects, which, we'll talk about briefly. If there's, whether those be lifelong or, current use side effects. If there's a fear of side effects, patients are scared of taking the medicines, which I'm sure people will have questions about. If the esophagitis is refractory to medical therapy, basically you see persistent inflammation despite medicine that we would see like on the 24-hour pH impedance. If people are having aspiration symptoms that they can't get better, basically, I have a patient like this as well who needed to get an anatomical surgical intervention because she kept getting aspiration pneumonias. If someone has persistent symptoms documented to be caused by refractory GERD on pH impedance testing, that's also an indication to get an anatomic intervention or some sort of surgery. Because the last thing we'd want to do is get complications of GERD, which, could be things like Barrett's esophagus, where the cell lines of the esophagus change and are technically precancerous. And in a small percentage of people, that could go on to cancer. So that's why, we not only want to treat symptoms, we want to make sure that inflammation gets all healed up. So the Nissen fundoplication is basically and I'll show you a picture of that here, is basically we make a wrap, or the surgeons rather, make a wrap with the fundus, hence the term fundoplication. They take the fundus of the stomach and create a wrap, sutured to the lower esophagus below the diaphragm. And what is that essentially doing? issue with the lower esophageal sphincter that presumably was allowing acid to come back up, now we're, kind of wrapping it to prevent that from happening again. And this is just a graph that shows the Nissen in an older study, Nissen, that surgery versus PPI, over, 5 years. And it showed, proportion in remission, omeprazole, which is, Prilosec, one of the PPIs versus surgery, and surgery slightly outweighed it, but the p-value usually, we want to see that less than 0.05 was not really significant. So not sure how reliable that study was. Now, the toupee is kind of like very similar to the Nissen, but we don't make a full 360. It's, it's less of a degree. It's usually about 270. And why do we do that? Because sometimes, as you can see from this schematic, one of my concerns, well, now all of a sudden you made this too tight, you can't swallow, or you could swallow, but it feels like stuff gets stuck. So in people who may have symptoms of, feeling like food's getting stuck, this is thought to be a better option because you're not creating as much of a wrap. Yes, are you possibly allowing more acid reflux to come back up? Potentially. But this is the preferred approach for refractory GERD in the setting of a known esophageal dysmotility. You have some swallowing issues. So the gastric bypass surgery is an interesting option because what are we doing with bypass surgery? We remove, overwhelming majority of the stomach, which makes all the acid. So if we're removing that, so in a patient who's got morbid obesity, who meets criteria for bariatric surgery, and who has concomitant simultaneous reflux disease, this is a great option because you kind of kill two birds with one stone. You're helping them hopefully with their weight loss, but you're also, decreasing the amount of stomach present, and thereby helping with their symptoms and or esophagitis if present. This just shows a picture of the Nissen versus the toupee, and that's a picture of the bypass. So this is the magnetic sphincter augmentation. So this is interesting. Basically, by placing a ring of titanium beads around the lower esophagus, and basically causes the increase or augments lower esophageal pressure with the magnetic fields to 15 millimeters of mercury, and then basically, to allow food to go down, it basically, the pressure, kind of, if you remember your days of physics, the pressure behind that area builds up and allows food to pass. I'll be honest, I've had one or two total patients that I've referred this for, who've done okay with it, but it's definitely not something first line that I typically recommend. And these are what the beads look like. So, it creates basically, a tighter LES around the esophagus that's placed surgically, a tighter sphincter. And then when we swallow food, it kind of, opens up by that pressure buildup. Here are just some guidelines, because that's what we do a lot in medicine, that surgical therapy is a treatment option for long-term therapy in GERD patients. It's as effective as medical therapy for carefully selected patients for chronic symptoms. It's not recommended in patients who do not respond to PPI therapy. And that last one usually meaning if they don't get better with medicine and we've done quantitative reflux testing and it's not, there's no evidence of acid reflux, we're not doing surgery on these patients. This is all to correct refractory GERD, not responsive to medicine in someone who has true acid reflux. Usually after surgery, we recommend, for them to undergo pH testing. Preoperative before surgery. Like I said on the earlier, it's not postoperative. Before surgery, usually we recommend patients to undergo testing to confirm they are actually having acid-mediated injury or symptoms related to acid. And we also want to make sure that they get appropriate manometry, the swallowing testing that we talked about, to make sure they don't have a motility issue. Because if they have a motility issue and you were to do that Nissen procedure, then all of a sudden the food won't be able to get down and you're going to have a bigger problem. And like we said earlier, bariatric surgery, obese patients with concomitant GERD should consider the gastric bypass. Here are some of the endoscopic interventions. Now, I don't perform any of these. I would say there's, a handful of people in this entire country who perform these surgeries. Typically you're going to find people who do this at big academic centers. So we'll talk about them briefly. This is the radio frequency energy delivery procedure. Basically, there are ablations that are performed at 6 levels at the lower esophagus, connection between the esophagus and the stomach. And you basically ablate this area to allow, and the device is called the Stretta, to allow any, to help augment that the LES from being too open or relaxed. This is called the TIF. So this is the transoral incisionless fundoplication. So this is another endoscopic procedure where you're basically doing the same thing as the fundoplication, but we do this endoscopically versus via an endoscopic device. And it makes a similar wrap like the toupee, not the full 360. This is a video, which I don't believe will, well, maybe it will work. I don't know if you can see this, but we could, this is the
rotated, wrapping the fundus toward the lesser curvature of the stomach. Under visual control, the esophagus device is then used to deploy 2 H-shaped fasteners to hold the fold of tissue in place and maintain the wrap. The wrap is then tightened further, and the next pair of fasteners are placed 1 centimeter above the Z-line.
And then this is kind of what it looks like after. As you can see,
a long 3 to 5 centimeters.
There's a nice tight wrap to prevent acid reflux from going up. And then this is the stapler, where there's, again, another device, an endoscopic system that contains ultrasound sensor to facilitate firing of 3 rounds of titanium staples. And this also kind of creates this, what we call wrap, not as high of a degree as the, obviously the surgical techniques or the TIF, as we just showed on the other side, but some degree of a wrap. And then lastly, this is the ARMS and the ARMA, which are the anti-reflux mucosectomy or mucosal ablation. And this is basically almost like surgical endoscopy, where we kind of get down to the muscular layer and cause scarring at that site, which leads ultimately, when there's scarring that occurs, it leads to tightening of the enlarged, that junction, the connection between the esophagus and the stomach. So just some guidelines again, endoscopic therapy cannot be recommended as an alternative to medical or surgical therapies. So usually these, unfortunately, like I said, these are not really only approved at, only performed at academic centers. Very difficult to get approval for these because there's really no guidelines. I know these are from 2013, nothing else has come out yet, but obviously patients who fail medical therapy prefer a less invasive option than surgery. This is an option. So just as a summary slide, I know we have about 25 minutes left, so we'll open up for questions. But so PPIs, these are our Prilosec, the Nexiums, the Acifexes remain the most potent acid-reducing agents in our medical arsenal for treating GERD. If a patient continues to be symptomatic despite PPI therapy, ensure they are taking their medication correctly. Confirm refractory GERD with 24-hour pH impedance testing. And obviously perform any other non-invasive, procedures, endoscopy, whatnot. Prior to any anatomic intervention for reflux, check esophageal function with manometry to exclude dysmotility. So you want to make sure there's no motility issues. Anatomic intervention remain the best option for improving the mechanical barrier to gastroesophageal reflux, as new options show promise as alternatives to Nissen. So these are all our surgical options in patients who don't get better with medicine. And endoscopic techniques to bolster the anti-reflux barrier show promise, with sample size and durability now available. So, we are, as time goes on, these endoscopic options likely will become the standard of care at some point in time when we get enough data and we see, and most importantly, insurance companies start to approve it as first line in patients who don't get better with medicine. And that's it. This is a nice picture of the New Valley Hospital that's going to be ready for services, I think, in about 14 months. And I'm happy to open up to questions.
Okay, thank you so much. That was so thorough and interesting. Someone has a question. What are the concerns for people over 50 taking PPIs causing osteoporosis?
Yeah, so I get this question in my office all the time. So we never want to keep, so the bottom line is this, in medicine and in general, you never want to keep someone on medicine if they don't need to be. So the bottom line is, like I said, with GERD, we want to make sure the symptoms are well controlled and there's no evidence of, major esophagitis or Barrett's esophagus, which is why any guidelines will say anyone above the age, it used to be 55, then they changed it to 60. Anyone above that age with chronic or new reflux symptoms should have an endoscopy. So to answer the specific question about osteoporosis, so the wording of this is in the terms of the question, causing none of the side effects or adverse reactions that you will read on the internet or on Google or WebMD or wherever. There's no causality, there's no causal relationship, there's no associative or a correlative relationship at all. These reported reactions, things like chronic kidney disease, osteoporosis, C. difficile diarrhea, Alzheimer's disease, which that theory has now been totally debunked, were all came from observational studies. So basically what they did was all these researchers who wanted to make big names for themselves took a look at one of the most commonly prescribed medicines like Prilosec, this class of drugs. And all they did was they looked at all of these very old people, and I'm talking about old, at least 75, 80-year-old people who not only were old, but were very, very ill with multiple medical problems, and looked at all their diagnoses and also looked at the medications that they haven't done. All they did was made an observation that, and worded it in a very, odd way, a very tricky, shifty way of basically that they observed that people who were on these medicines happen to have basically had these diagnoses rather. Needless to say, I would say the two most common side effects that even, I'll play devil's advocate, the ones that I get concerned about are number one, osteoporosis, and number two, C. difficile diarrhea, not so much even chronic kidney disease. And I have conversations with rheumatologists, endocrinologists who may be treating, osteoporosis and chronic kidney disease. So if I don't need to keep a patient on a medicine, I won't. Meaning if they have a symptom of heartburn and I do their endoscopy and it's clean, I feel confident that I could try to get them to the lowest effective dose, try to get them from the higher dose of 40 milligrams once a day or 40 milligrams twice a day to 40 once a day or 20, or even switch them to Pepsid, which is a different class of drugs that does not even have any of these reported observational, observational side effects. So my concern is, in someone who basically needs to be on the medicine, they need to be on the medicine. Most people would rather, if you were even to take that as truth, the osteoporosis, I think, you'd rather have osteoporosis than esophageal cancer. Everything in life has pros and cons. But again, I don't really think that there's any real causality, a correlation or association between the two.
Okay, thank you. Another question, have you seen any changes post-COVID regarding acid reflux or?
Yeah, that's an excellent question. I have a lot of patients, especially ones with long COVID, are presenting with new reflux that they didn't have before, and it can be challenging to treat because a lot of it is non-acid reflux. So they don't always get better with PPI. Some do. But yes, I have seen a good number of people, and usually that's more with the long COVID, the unfortunate people who have long COVID symptoms.
Okay. All right. Well, I think that's about it. Thank you so much, Dr. Herman. That was an excellent presentation.
No
Somebody,
problem. There is another question that came in. I just see it on the panel.
oh,
Pepsid versus Pepsid.
okay, just saw it. Okay, go
Yeah,
ahead.
yeah. No, it's okay. I'm happy to help. Pepsid versus Pepsid AC. Yeah, I mean, either one. Usually, if patients who have nighttime symptoms or they're, for whatever reason, work late, they work late at night, or they can't have they have trouble of adhering to good lifestyle changes with laying down after eating. I'll usually say Pepsid AC, they should take it at bedtime. But really it doesn't make a difference, in terms of whatever the dose is, the dose is. Usually it's just more of a lifestyle thing. Another question I see here, would you stop PPIs due to fundic gland polyps? Absolutely not. Fundic gland polyps are completely benign. We'll see them all the time, whether a patient's on PPIs or not. PPIs are known to cause that, which I know we didn't really. All right, it's just, that's a real cause, but they're completely benign and cause no problems. They have no adenomatous or precancerous components to them.
Okay, I think that's it. Thank you so much. Really appreciate your time.